Patients here.
Oh boy, got some blood going.
Yeah, this is with blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
her left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today we are wading into waters that I think terrify just about everyone, parents, teachers, and honestly, even a lot of seasoned medical professionals.
Oh, absolutely.
We are looking at the pediatric brain, specifically when it kind of goes rogue.
Yeah.
We're talking about seizures.
It's a heavy topic.
Yeah.
Now, in this sack of research we're looking at today, the nursing textbooks, the clinical tables, specifically table 16.2, plus those dense lecture notes, there is this undercurrent of urgency.
Mm-hmm.
Because when a child has a seizure, it looks chaotic. It looks like a medical catastrophe.
I feel like a system crash. I mean, looking at the descriptions of a tonic-clonic seizure, it's violent.
It is violent. And for a nurse or a parent, the instinct is to panic. The adrenaline dumps, and you want to do something immediately.
Right, you want to fix it.
But the materials we are diving into today make a very specific promise. They argue that if you can move past the fear, seizures actually follow a very strict set of rules.
That's what jumped out at me. I went into this expecting just a list of terrifying symptoms, just a catalog of bad things.
Right.
But what we actually have here is a logic puzzle. The sources call it a classification system, but it feels more like a map.
It is a map, and that's our mission for this deep dive. We aren't just going to memorize a list of jerks and twitches. We are going to try to build what I call a safety brain.
A safety brain. I like that.
We want to get to a point where if you see a child in distress, you aren't thinking, oh my God, you're thinking, okay, looking at the map, I know exactly where we are and I know exactly what to do.
That's the goal, right? To move from panic to a plan. Because looking at these notes, there is a lot of noise. You have tonic, clonic, atonic, myoclonic, absence focal, complex partial, simple partial.
It's an alphabet soup.
It's an alphabet soup of neurology. It's so easy to get lost.
It is, and that's where students fail exams and where clinicians make mistakes. They try to memorize the soup. We need to apply the 80-20 rule here.
Okay, lay out the 80-20 rule for pediatric seizures. What are we focusing on?
So we're going to ignore the 1 in a million neurological outliers for a moment.
The House MD stuff.
Exactly. We're going to focus on the 20% of core concepts, that's classification, safety, and prioritization, that solve 80% of the problems you will face at the bedside or on the NCLEX.
Okay.
If you understand the mechanism, you don't need to memorize every single variation.
So less rare diagnoses, more emergency room practical survival.
Precisely. We need to know what kills the patient, what damages the brain, and how to keep them safe while the storm passes.
Okay, let's open up the map. The first thing the literature demands is that we stop thinking of a seizure as just shaking on the floor.
Right. Shaking is just one potential symptom. To really understand this, you have to look at the engine. You have to look at the brain as an electrical grid.
I like this analogy in the notes. So imagine a city like New York or London at night. The lights are on, traffic signals are working, everything is flowing. That's a normal brain.
Correct. Neural pathways are firing in an organized sequence. A seizure is an electrical storm. It's a massive, uncontrolled discharge of energy.
Mm-hmm.
But, and this is the absolute key to the entire deep dive, the name we give that storm depends on two questions.
Question 1, where did the lightning strike?
Yes, the location of the onset. Did it start in one specific building, in one neighborhood, or did the entire grid short-circuit simultaneously?
And question 2, did the lights go out?
Exactly. Consciousness. Did the patient stay awake, or did the system crash? If you can answer those two questions, location and consciousness, you can classify almost any seizure you'll ever see.
So let's apply this to the big buckets in table 16.2. The first bucket is generalized onset. Using our grid analogy, this sounds like the worst case scenario.
It's the citywide blackout.
Yeah.
In a generalized onset seizure, the electrical discharge involves both hemispheres of the brain, the entire city, from the very first millisecond.
So there's no warning, no buildup.
None. Just bam, the whole grid is hit.
And because the whole brain is involved, I'm assuming the lights question is pretty easy to answer.
There is almost nowhere for consciousness to hide. If your whole brain is seizing, you cannot be conscious.
Yeah.
You might not be on the floor shaking, but you are not there.
Right.
You aren't processing information. The reticular activating system, the part of the brain that keeps you awake, is overwhelmed instantly.
Okay, so generalized equals whole brain and usually lights out. Now, the notes split this bucket into two subcategories that sound pretty self-explanatory: motor and non-motor.
And this is where the movies mislead us.
Yeah.
We expect the motor stuff, the flashing, the convulsions,
Sure.
but a generalized seizure can be non-motor. The person just stops, they freeze, the storm is raging inside, but the outside looks eerily calm.
We'll dig into those specific types, the daydreamers versus the drop attacks, in a bit. But I want to contrast the citywide blackout with the second bucket, focal onset.
Focal is the opposite. This is a transformer blowing up on a single street corner. The storm originates in one specific group of neurons in one hemisphere.
So the rest of the city might still have power.
Exactly. And this is where it gets tricky for the nurse or the parent observing. Because only part of the brain is offline, the child might still be awake.
This is that concept of the toggle switch regarding awareness. I found that really helpful.
Right. We classify these based on awareness. You can have focal with retained awareness. The child knows they're having a seizure. They might look at you and say, "My arm feels weird," or "I smell burning rubber." The lights are flickering, but they are on.
That sounds almost more terrifying than being unconscious. To be a witness to your own brain malfunction.
It can be incredibly traumatic for a child. They feel out of control, but they are fully present. They can hear you speaking to them, but they might not be able to control the twitching in their hand.
Yeah.
It's frightening.
But then there is focal with impaired awareness.
The switch goes down halfway. The storm in that one neighborhood spreads just enough to fog up the windows. They aren't unconscious, they aren't in a coma, but they aren't home either.
What does that look like?
They might look at you, but they look through you. They might answer a question, but the answer makes no sense. They're just not connecting.
So to recap the map before we zoom in, generalized is the whole grid, lights out. Focal is one neighborhood, lights might be on or they might be dimmed.
You've got it. And then there is the third bucket, the unknown onset, which is the medical way of saying we didn't see the start, so we aren't sure.
Right, the catch-all.
It is, but that's where we hide one of the most dangerous monsters in pediatric neurology, infantile spasms.
Which we will definitely get to because the research on that is urgent. But before we leave the high-level map, I want to test the safety brain theory. I'm going to throw a scenario at you, a pattern, and you tell me where it fits on the grid.
Let's do it.
Scenario 1. You're a school nurse. A teacher sends a note saying a 7-year-old student keeps spacing out during math. He just stares at the wall for 10 seconds, doesn't answer when called, and then snaps back and keeps working like nothing happened.
Okay, look at the grid. Is he moving? No. So it's non-motor. Is he conscious? No, he's not answering you. He's not processing, and he snaps back instantly. This is classic generalized non-motor, specifically an absence seizure.
Absence. It's such a perfect name. He's just absent.
He's gone for a few seconds, and the snapping back is the tell. If he was just bored, he'd be annoyed you interrupted him. If it's a seizure, he doesn't even know he was gone.
Right, there's no memory of it.
Not at all.
Okay, scenario 2. This one is more dramatic. A child is walking down the hallway and suddenly, boom, drops to the floor like a puppet with cut strings, hits his face, no bracing, no stumbling, just a complete drop.
Gravity takes over. That's a sudden total loss of muscle tone. We call that a tonic. A tonic for tone.
A tonic, got it.
That's generalized motor. And your safety brain should immediately be screaming, head injury.
Helmet.
Helmet, 100%. If you see a kid in the classroom with a helmet, assume a tonic seizures until proven otherwise.
Scenario 3. A toddler has a high fever, 104 degrees Fahrenheit. Suddenly, eyes roll back, shaking all over for 2 minutes, then stops and cries.
That is the most common one. Febrile seizure. It looks like a generalized motor seizure, but the trigger is the fever, the rapid rise in temperature. This is a specific pediatric category that requires calm education for the parents, not necessarily panic.
So it's scary, but it's not necessarily epilepsy.
Correct. It's a reaction, not a chronic condition.
Okay, I feel like I have the grid in my head. Now I want to get into the weeds. I want to go through section B, the seizure type breakdown. Let's start with the big one, the one that everyone pictures when they hear the word epilepsy.
The generalized motor, specifically the tonic-clonic.
The notes refer to this as the tonic-clonic, but I grew up hearing it called Grand mal. Why did we change the name?
Grand mal is French for great sickness.
It's dramatic, sure, but it's not helpful. It doesn't tell you anything.
It's a bit archaic. Very. Medicine is trying to be more descriptive. Tonic Clonic is a literal instruction manual for what the muscles are doing. Tonic means stiffening. Clonic means jerking.
So break it down. If I'm a new nurse or a parent and this starts happening, what is the sequence? Because the notes say it follows a script.
It almost always follows a script. And knowing the script is the only way to keep your cool when everything is chaos. Acts 1 is the aura. Now, this doesn't always happen, but when it does, it's a warning shot.
This is the pre-shock, the warning.
Right. And physically, this is actually a focal seizure happening before it spreads to the whole brain. The child might smell something distinct. Burnt toast is the cliche, but it could be anything. Or they get a sudden, overwhelming sense of déjà vu or dread.
It's the calm before the storm.
And then the storm breaks. This is Act 2, the tonic phase. And this moment is usually marked by a sound that parents never forget: the epileptic cry.
I've read about this. It's described as a scream, but the notes emphasize that it's not a cry of pain.
That's a crucial distinction for the family. It sounds like agony, but it's physics. The tonic phase means every muscle in the body instantly stiffens. That includes the diaphragm and the chest wall. They clamp down violently, forcing all the air out of the lungs through vocal cords that have also clamped shut.
So it's not a voice, it's just air.
It's a high-pressure squeak, a very loud, terrifying mechanical squeak. And at that exact moment, consciousness is gone. The child falls. The body is rigid, arms flexed, legs extended, back arched.
And because those chest muscles are clamped, they aren't breathing.
They are in apnea. They are not moving air. This is why you see cyanosis, that blue tint around the lips. As a nurse, this is the part that makes your heart stop. You're watching a child turn blue.
The instinct is to do something. Breathe for them, shake them.
And you can't. You have to ride it out. Because usually within 10 to 20 seconds, the brain shifts gears into Act 3, the clonic phase, the jerking.
This is the rhythmic part.
The muscles start rapidly contracting and relaxing. It's violent. And this brings us to the gross reality of seizures that textbooks sometimes gloss over, but you need to be ready for at the bedside.
The fluids.
There's a lot of fluid. Because the swallowing reflex is gone, saliva is pooling in the throat. The jerking churns it into a foam. It looks like something from a horror movie, but it's just spit.
And they might bite their tongue.
Often. So now the foam is pink or bloody, and simultaneously the sphincter muscles let go, so the child might wet themselves or have a bowel movement.
Okay, paint the picture. You have a child who is blue, thrashing, foaming blood at the mouth, and has lost bladder control. It is a scene of absolute chaos.
Total chaos.
So safety brain on. What is the one thing you see people do in movies that you must never, ever do in this moment?
You never put anything in their mouth.
Put a wallet in, put a spoon in so they don't swallow their tongue.
Myth. You cannot swallow your tongue. It's attached to the bottom of your mouth. But if you shove a spoon in there, you will chip their teeth, you will lacerate their gums.
Or worse.
Or worse, you'll trigger a gag reflex and make them vomit while they're on their back, unable to clear their airway.
You turn a seizure into a choking hazard.
You turn it into an aspiration event.
Yeah?
Exactly. And the other, do not restrain them.
Why? If they're thrashing, shouldn't I hold them down so they don't get hurt?
The force of a tonic-clonic seizure is incredibly powerful. The muscles are contracting with maximum force. If you try to pin a child's arm to the floor, the muscle contraction is strong enough to snap their own bone against your resistance. You will cause a fracture.
Wow.
So the nursing intervention is let it happen.
It's counterintuitive.
So counterintuitive, you let it happen, but you make it safe. You become the goalie. You push away the furniture. You put a pillow or a jacket under their head so they don't crack their skull on the linoleum.
Okay.
And if you can, only if you do it safely, you roll them to their side.
You drain the foam.
Gravity is your suction. Let the saliva run out so it doesn't go into the lungs.
Okay. The jerking stops. Silence falls. The seizure is over. But the episode isn't, right? The danger's not over.
Not even close. This is Act 4, the postictal state. And this is where the tonic-clonic is unique. The brain has just run a marathon at a sprint pace. It is chemically exhausted.
So the child doesn't just pop up and ask for a snack.
No. They are dead weight. They are usually difficult to rouse, confused, maybe combative if you try to wake them. They need sleep, deep sleep, for 30 minutes, maybe 2 hours.
And this is a diagnostic clue.
Huge clue. If the teacher says he shook for a minute and then went right back to math, that wasn't a tonic-clonic.
Right.
If they say, he shook and now he's been asleep in the nurse's office for an hour and doesn't know his own name, that's tonic-clonic. The recovery time tells you the severity of the storm.
Before we move off the generalized motor types, we mentioned a tonic earlier, the drop attack. Is there anything else about that one we need to lock in?
Just remember the Lennox-Gastaut connection. It's a severe form of childhood epilepsy. These kids have mixed seizures, tonic, atonic, absence. But the atonic ones are the most dangerous for daily life because they happen without warning. The helmet isn't a fashion statement, it's a medical device.
It's essential equipment.
It is.
And myoclonic, that's another motor term.
Think of the myo meaning muscle and clonic meaning jerk. But myoclonic is like a lightning strike. It's a single massive jerk. You know when you're falling asleep and your whole body kicks?
A startle response?
Yeah, it's a hypnic jerk.
It's like that, but while awake and much more violent, it's usually brief milliseconds. But it can be strong enough to make a child throw a spoon across the room or fall out of a chair. It's a sudden, powerful misfire.
Okay, let's flip the coin. Still generalized, so whole brain but non-motor. We talked about the daydreaming student, the absence seizure.
Formerly PEDI, little sickness.
Why do exam writers love this one so much?
Because it's a trap. It looks behavioral. It looks like ADHD. It looks like a kid who's just not listening. So walk us through the differentiation. I'm a parent. My teacher says my kid isn't paying attention. How do I know it's not ADHD?
Look at the interruption. In ADHD, the child is distracted. They're looking out the window, fidgeting. If you call their name, they usually look at you, maybe with some annoyance.
They're still there.
They're present. In an absence seizure, the brain is offline. You can wave your hand in front of their face, and they won't blink. They're completely unaware of their surroundings.
And physical signs? Are there any?
Very subtle. You might see eyelid myoclonia, the eyelids fluttering or rolling back slightly, or maybe a tiny rhythmic smacking of the lips. But the key is the duration. It's short, 5 to 10 seconds. And then, snap, they are back.
No postictal confusion.
None. Zero. They pick the sentence exactly where they left off. They have no idea any time has passed. That's the hallmark.
That feels like it would be incredibly hard to catch if you weren't looking for it.
It is. Often these kids get diagnosed because their grades tank. They are missing 50 chunks of information a day. It's like watching a movie with a scratched DVD that keeps skipping scenes. You lose the plot.
Okay, let's move to the second big bucket, focal onset. We talked about the toggle switch. Let's start with focal, with retain awareness. The child is awake.
This is all about location, location, location. If the seizure is in the motor strip for the hand twitches. If it's in the sensory strip, they feel numbness or tingling.
What about the temporal lobe? I've heard those can be weird.
The temporal lobe handles memory and emotion. So a focal seizure there can cause psychic symptoms. Sudden unexplainable fear, a wave of sadness, or déjà vu, that feeling that I've been here before. It's a memory firing at the wrong time.
And since they are awake, they can tell you.
They can describe it. Mommy, the room looks small. Mommy, I smell rotten eggs. It's a sensory hallucination, but they know it's not real. They are observing their own brain's strange behavior.
Now, if the toggle switch slides down focal with impaired awareness, this used to be called complex partial.
This is the most common type of seizure in adults, but we see it in kids too. The consciousness is clouded, and this is where we see automatisms.
What exactly is an automatism?
It's an automatic, repetitive behavior that serves no purpose. Lip smacking, chewing, picking at the buttons on a shirt, rubbing the hands together, walking in circles.
It sounds like fidgeting or a nervous habit.
It does. And in an infant, this is a nightmare to diagnose. Babies smack their lips all the time. They cycle their legs. They suck on their fists. It's normal behavior.
So how do you differentiate normal baby stuff from a seizure?
You try to interrupt it. If a baby is just playing or self-soothing and you gently hold their hands, they will look at you and stop. They'll react to you. If it's a seizure, the movement will continue, or they will fight against the restraint with a rhythmic, unnatural force, and they won't make eye contact. They'll look right through you.
That's a huge clinical pearl. Can I interrupt this?
Exactly. If you can stop it with a gentle touch or distract them, it's probably not a seizure.
Now, we need to talk about the emergencies, the monsters. Section 4, status epilepticus.
This is the code blue of neurology. This is the one you have to act on. Fast.
What is the official definition? Because I feel like it's changed.
It has. It used to be a seizure lasting 30 minutes. But we realized that if we wait 30 minutes, the brain is already cooked. So the operational definition now is a seizure lasting longer than 5 minutes, or repeated seizures, where the patient doesn't wake up in between.
So if a child has a seizure, stops, and then starts another one 2 minutes later without ever waking up.
That's status. You start the clock, and you don't stop it until they are back to their baseline consciousness.
Why is time such a critical factor here? What's happening in the brain?
Think about the electrical grid again. If you run the grid at 500% capacity for a sustained period, the wires melt. During a seizure, the brain's metabolic rate skyrockets. It is devouring oxygen and glucose at an insane rate.
So the brain is starving.
Starving, and it's frying. After about 5 minutes, the body's compensatory mechanisms fail. You get hypoxia, which is low oxygen. You get hypoglycemia, low sugar. And eventually, neurons start dying. Permanent brain damage.
Okay, so I'm the nurse. I look at my watch. It's been 6 minutes. The seizure is not stopping. What is the priority?
ABCs. Airway, breathing, circulation. Always. If they aren't breathing, you bag them. You get oxygen on them. You make sure they have a pulse.
And then drugs?
You need to stop the electrical storm. The first line of defense is benzodiazepines, lorazepam, which is Ativan, or diazepam, which is Valium.
How are those given?
Often given IFED if you can get a line in a seizing child, which is hard. So there are other roads. Rectal diazepam is very common for home use. Intranasal midazolam is also an option.
Why benzos?
They are the emergency stop button. They work fast to flood the brain with inhibitory signals, basically telling the neurons to calm down, but they wear off fast. So you can't just give Ativan and walk away.
You need a backup, a long-term plan.
You need a maintenance drug, something long-acting to keep the seizure from coming back. That's usually fosphenytoin or phenobarbital. Given
So stop it with benzos. Keep it stopped with phenytoin.
Correct. And while you are doing that, check the glucose. Get a finger stick.
Because the brain ate it all.
Exactly. Or because low blood sugar caused the seizure in the first place. If the glucose is 20, all the Ativan in the world won't fix it. You need dextrose. You have to treat the cause.
Got it. Now the final specific type. This one was listed under unknown onset in the notes, but you flagged it as a developmental emergency. Infantile spasms.
West syndrome? This is the one that pediatricians are terrified of missing.
Who gets this? What's the age range?
Babies.
Yeah.
Usually 3 to 12 months old. The peak is around 4 to 6 months. It's rare to see it start after 18 months.
And what does it look like? It doesn't look like a grand mal, right?
Not at all. It looks like a jackknife. Imagine the baby is lying on their back. Suddenly, their head crunches forward, knees come up to their chest, and arms fling out to the side. It's a sudden flex.
It's like a crunch exercise at the gym.
Exactly. And it happens in clusters. Crunch, relax, crunch, relax. It might happen 20, 50, 100 times in a row, often right after they wake up in the morning or from a nap.
And the parents think it's colic or startle reflex.
They think it's a tummy ache. Oh, he's pulling his legs up. He must have gas. Or they think it's just the Moro reflex. But it's rhythmic and clustered, which is the key difference.
Why is this an emergency? It sounds relatively mild compared to the shaking of a tonic clonic.
The seizure looks mild. The consequence is devastating. Infantile spasms are a sign of a chaotic, disorganized brainwave pattern called hypsarrhythmia. It's electrical chaos.
Yeah.
If you don't stop it, the brain stops developing.
Stops.
And often regresses. The baby who is smiling and cooing and rolling over suddenly stops smiling, stops rolling. If you miss this diagnosis for a month or two, that child may never recover those milestones. Severe cognitive disability is the outcome.
So if a parent describes rhythmic crunching in their baby,
You order an EEG immediately. Do not wait. This is a time-is-brain situation, just like a stroke.
and the treatment, is it the same as other seizures?
It's weirdly specific. It's not standard seizure meds like Keppra or phenobarbital. We use ACTH, adrenocorticotropic hormone. It's a steroid injection, or a medication called vigabatrin. But you need a pediatric neurologist, and you need one now.
Wow. Okay, that is a heavy list. But I feel like I can see the differences now. I want to move to section C, comparison tables. Let's synthesize this. If we're building a cheat sheet for the exam, let's visualize the postictal state column.
Great idea. The aftermath column. This is a huge differentiator.
Okay, so let's run through them. Absent seizure.
Postictal state. None. Immediate return to baseline. It's like a light switch flipping off and on.
Tonic, clonic.
Postictal state. Severe. Deep sleep, confusion, amnesia, muscle soreness, headache. Can last for hours.
Focal with retained awareness.
Postictal state. None. They were awake the whole time. They might be tired or scared, but they're not confused.
Then focal with impaired awareness, the one with the automatisms.
Postictal state. Mild confusion. They might feel groggy or disoriented for a few minutes, but they are not comatose like the tonic-clonic. They kind of come to. and wonder where they are.
That is extremely helpful for differentiating. Now, let's do a safety priority column. What's the #1 thing to worry about for each?
Okay, let's do it.
Tonic, clonic.
Priority: airway and physical protection. Side lying, clear the area, cushion the head.
Tonic.
Priority: head protection, helmet, supervision during walking, especially on stairs, preventing trauma from the fall.
Status epilepticus.
Priority: life support, ABCs, oxygen, glucose, 5E access, stop the seizure with meds. It's a medical rescue.
Infantile spasm.
Priority: developmental preservation. The emergency isn't the seizure itself, it's getting the diagnosis. Immediate referral and diagnosis to save the brain.
It really is a map. Once you know what you're dealing with, the priority highlights itself.
Exactly. The diagnosis dictates the action.
Let's move to Section D, exam strategy and nursing management. You called yourself an NCLEX coach. Why do exam writers love this topic so much?
Because it tests everything. One question about a seizure tests your knowledge of anatomy, your safety instincts, your prioritization skills, and your pharmacology knowledge. It's an incredibly high-yield topic.
Okay, so let's talk about the traps, the distractors. We mentioned the tongue blade.
If you see padded tongue blade or insert oral airway during an active tonic-clonic seizure, eliminate that option immediately. It is always wrong. You will cause more harm.
What about restraints? The option that says something like, gently restrain the limbs.
Hold a child's hands to prevent flailing. Wrong. You will cause injury. You never fight the seizure.
What about go get help? That seems like a good idea.
Careful. The wording is key. If the option is leave the room to find a doctor, that's usually wrong. You never leave the patient alone during a seizure.
So what do?
You yell for help, you hit the call bell, but you stay at the bedside to monitor the airway and time the event. Your first action is to ensure safety, not to abandon the patient.
Timing. We haven't stressed that enough. Why is the nurse looking at their watch?
Because the doctor isn't there. You are the eyes and ears of the medical team. The difference between a 2-minute seizure and a 6-minute seizure determines if we give emergency drugs.
It's the status epilepticus trigger.
It is. And the difference between started in the right hand and started all over determines the diagnosis focal versus generalized. Your documentation is the diagnosis in many cases.
Let's touch on family education. Febrile seizures versus epilepsy. Parents must be losing their minds.
This is a huge source of anxiety. A febrile seizure happens because of a rapid spike in temperature in a young child, usually between 6 months and 5 years of age.
Is it epilepsy?
No. By definition, it's not. It does not mean the child has epilepsy. It does not mean they have brain damage. It's a reaction of an immature brain to the fever.
So what do we tell the terrified parents?
We reassure them. We treat the fever with antipyretics like acetaminophen or ibuprofen. We tell them it's likely benign. But we teach them seizure safety just in case it happens again. However, we distinguish that from unprovoked seizures, which are seizures without a fever. Those require a full neurologic workup.
And for the child with known epilepsy, the school-age kid, what about seizure precautions at home? What's practical?
It's about balance. We don't want to wrap them in bubble wrap, but water is a major risk. Showers are safer than baths. If they have a seizure in a bath, they can drown silently.
And swimming.
Only with one-on-one supervision, someone whose only job is to watch that child.
And heights, like bunk beds or climbing trees.
Padded side rails on the bed can be helpful. Maybe the bottom bunk is a better idea. And for climbing, it's a risk assessment. How frequent and severe are the seizures? It's about empowering the family to make reasonable, not fearful decisions.
This has been incredibly clarifying. Let's head to the outro.
Let's bring it home.
We've covered a massive amount of ground, from the electrical grid to the jackknife spasm. If the listener takes away just 3 things from this whole deep dive, the big 3, what should they be?
Number 1, safety first. Your primary job is not to stop the seizure with your bare hands. It's to protect the patient from the environment and protect their airway. Side lying, no restraints, nothing in the mouth. Protect the head.
Number 2.
Know your if-then patterns. If they're staring and snap back, the absence. If they drop like a stone a tonic. If they are a baby doing rhythmic crunches and infantile spasms. Classification dictates treatment and priority.
And number 3.
Respect the emergencies. Status epilepticus is a metabolic fire that burns the brain. Infantile spasms are a developmental wall that stops growth. You have to move fast on those. Time is brain.
I want to leave everyone with one final thought. We spend so much time focusing on the seizure itself, the dramatic event, the shaking, the fall. But I keep thinking about the postictal phase.
It's the invisible part of the illness. It's the part no one sees.
Imagine a 10-year-old girl. She has a tonic-clonic seizure at 7 a.m. She's technically recovered by 8 a.m., but her brain is in a fog until noon. She goes to school, but she can't process math. She feels slow. She feels stupid. The teacher thinks she's not trying.
And if she has nocturnal seizures, seizures in her sleep,
Yeah.
she wakes up exhausted every single day with a headache, and she doesn't even know why.
Exactly. We judge these kids on their behavior or their grades, but we forget the physiological toll of the recovery. The safety brain isn't just for the 5 minutes of the seizure, it's for understanding the whole child, the whole 24-hour day.
That is beautifully said. It's holistic care. It's seeing beyond the event.
Thank you so much for guiding us through the map.
Sure.
To the learner listening, you now have the grid. You know where the transformers are. Go crush the NCLEX, and more importantly, go be the calmest person in the room when the storm hits.
You've got this.
Thanks for listening to The Deep Dive. Catch you next time.